Thank you, Donna, for that kind introduction, and thank you all for being here today. I imagine most of you are either not basketball fans or have a working DVR at home, one of the two. So I have prepared some slides related to high blood pressure, related to current knowledge of the condition. And then I have some slides related to things to look for in the clinic coming down the road, hopefully in the next few years. There are about 36 slides. We can spend all of the time on one of the slides or none of the time on all of the slides. It's totally up to you. I believe the format of this session is that I will try to get through the slides and then at the end we'll save the questions for then. But if I go astray or there's some clarification that you have right there and then, it's okay if you want to ask at that time. That's fine too. I'll go ahead and get started. Oh, actually probably one point here. You have to give a lot of lectures when you're at Stanford, so I spend a lot of time on symbols. You'll see several symbols throughout this lecture. The two symbols I chose for this have to do with what we know now and what we ought to know. For a show of hands, for those in the audience, how many people own or have a blood pressure cuff at home that they use? Okay, quite a few. How many people have a smartwatch that they use for anything? Okay, not so many. Okay. We'll get to those points as we go through the lecture. So just for full disclosure, I'm on a couple of different scientific advisory boards, which I've listed here. The first one is for a company called Paramus, which started out of bioengineering here at Stanford, and is a company involved in making sort of a 21st century device for measuring blood pressure. I also advise a company called BioInnovate Ireland, which is also doing something similar in Ireland. And then I'm on the advisory board for a company that makes a drug related to kidney disease called Wearables. So what we know now. So I think it's important to start off with some basic facts about high blood pressure and why do we care? Because for many years, people really didn't care that much. Well, high blood pressure affects a lot of people. It affects about 1/3 of the US population. And more than half of all Americans who are 65 years or older have high blood pressure. So it's pretty common. What is perhaps the most striking is that more than half of the individuals that have high blood pressure don't have blood pressure under control. That is probably more so now than it was 2 years ago, when the target blood pressure that we all aimed to get to was lowered based on clinical studies and based on national guideline recommendations. In this lecture, I'm going to show a few slides. I'm going to show results of a clinical trial, just a tad bit of research data, but mostly talk about general concepts. But the concepts that I will talk about from a research standpoint relate to the actual number for the blood pressure target that we want to get to. So this is an important point, that half of all individuals with the condition aren't under control. We care about this because hypertension is a major risk factor for major life-altering diseases. So what would those be? So we can think of the long-term sequelae of hypertension related to several different organs, but I've tried to encapsulate some of the more critical ones here. So high blood pressure can lead to heart disease. That can be in the form of myocardial infarction or a heart attack, or in the form of heart failure. High blood pressure can also cause brain disease. That can be in the form of carotid artery disease, or in severe cases, stroke. And in long-term, dementia has been associated with higher blood pressure. High blood pressure is also famously associated with kidney disease in multiple ways. And although I'm a nephrologist, I'm going to be wearing a blood pressure hat for today. But just at this juncture, I'll let you know that high blood pressure is both a cause of kidney disease, it is an exacerbator of existing kidney disease, and it is a consequence of kidney disease. So kidney disease and high blood pressure go hand in hand. High blood pressure can also damage the blood vessels. So that can be of relevance to heart disease. That can be of relevance to carotid artery disease and stroke. But that can also be of relevance to what we call peripheral arterial disease, which you may have heard of in prior sessions of this health lecture series, related to disease to the blood vessels that go to the arms and the legs. High blood pressure is also a critical risk factor for disease during pregnancy. So things like preeclampsia, things like premature birth are related to high blood pressure. So I've tried to list a number of the conditions here. This is not all-encompassing, but I tried to hit some of the highlights as to why we care about blood pressure. And certainly there are acute consequences of high blood pressure, and I didn't really cover those here. But what we're talking about here are the long-term risks of hypertension. So there's a lot to care about. So what's shown here is a graph with arterial blood pressure on the y-axis and a year worth of data spaced about a month apart on the x-axis. The top line is the systolic blood pressure, and the bottom line is the diastolic blood pressure. So that's sort of the upper and lower limit, if you will, of the blood pressure. And the arrows refer to different time points at which something happened for this individual. Along the bottom, and I don't know if this will show up on the video, but I will try. Along the bottom here, do we have a pointer by any chance, or does that not translate very well in video format? No. Okay, that's okay. I'm just going to stick my hand over here just for a second. These two terms here, an electrocardiogram or EKG, and LVH refers to left ventricular hypertrophy, which is a thickening of the heart. So that's a consequence of high blood pressure. And proteinuria, or protein in the urine, is a readout for kidney disease, so a consequence of high blood pressure. And this individual had a thickened heart at this time point and had measurements of a marker for kidney disease at the points in plus. Does anybody know who this individual is? Yes? Sorry? No?
Maybe Dick Cheney?
It's not Dick Cheney. He's had a lot of heart disease, but it's... Sorry?
Is it you?
It's not me. No. Thankfully, it's not me.
Bill Clinton?
And it's not any of you. It's not Bill Clinton. This is an individual that's passed away. This is Franklin Delano Roosevelt. This is his blood pressure, and the arrows refer to various events in and around 1945. And when I say that why we care, it's because people didn't care for a long time. Hypertension has long been known as the silent killer and has afflicted individuals throughout human history, this being one of the more celebrated examples. Franklin Roosevelt died of a brain aneurysm. And as noted, there was, quote unquote, no indication of imminent danger, despite the fact that this blood pressure was astronomically high, with blood pressures getting as high as 200 millimeters of mercury, which would send anyone to the emergency room these days, and having already demonstrable consequences of high blood pressure long before the event. So thankfully, hypertension care has improved since this time. And I'd like to go through a little bit about where we are with that hypertension care now. So this is another graph, or grid rather, that outlines the current goal blood pressures. So if there's one particular slide to take away from this first part of the talk, it's probably this slide. So these refer to different stages of hypertension or conditions. And the first column is the systolic blood pressure level, and the second column is the diastolic blood pressure level. This is what physicians use to categorize or phenotype patients that come to see them. And so we start off with what is considered normal blood pressure, which is less than 120 over 80. The second category is sort of pre-hypertension. This is a category that's really hard to name because it comes with a lot of baggage when one names a condition like this. But that is considered to be 120 to about 130 over something less than 80. So a blood pressure of 125 over 75 would fit in that category. The next step up is hypertension, which is starting with stage 1 hypertension, when the blood pressure, the top number, the systolic blood pressure, is between 130 and 139. And the bottom diastolic blood pressure is 80 to 89. And this is an and/or table. So if you have a blood pressure of 125 over 85, you would fit this category, because even though your top number is less than 130, your bottom number is greater than 80 millimeters of mercury. And the last category is stage 2 hypertension, which is when the blood pressure is greater than 140 for the systolic, and or the diastolic is greater than 90. So these are the newest recommendations based on a number of different societies. They are not uniformly agreed upon nor uniformly followed, but they are one of the more popular national guidelines, and that's why I chose to show it to you here. I forgot to describe my symbols. I just realized. This, the cuff in the bottom right is, that symbol is a sphygmomanometer. That's something that is attached to all of the home blood pressure monitors that you all have. It's a cuff and a bladder, and we'll go over that just a little bit. But I hope that that's fading. I hope that the use of these things are fading over time, and I'll explain why. And I hope that the use of a smartwatch will come into play in the near future. Yes?
A quick clarification question.
Sure.
Somebody said that these diastolic numbers are more important than systolic numbers. Is there true? Or?
So the question is, which, if either, is more important, systolic blood pressure or diastolic blood pressure? The simplest answer that I can give you is they're both important. I tend, personally, and every physician is different, I tend to go by the systolic blood pressure more, in particular, just as a simple way of tracking things, but also because it's more common than not that the two of them will track together. There are cases on the periphery of the normal where the two are completely disjointed. Then it's a bit more of a difficult management issue. But in general, I follow the systolic blood pressure a bit more than I follow the diastolic blood pressure. But in reality, one follows both and looks at both, if that helps clarify that. So what this slide is, this is a history slide. So this is a slide of the level of target blood pressure above which is considered hypertension for different guideline recommendations over time. So on the y-axis is blood pressure in millimeters of mercury. In blue is the systolic blood pressure goal, and in orange is the diastolic blood pressure goal. And on the x-axis is a time scale from 1966 to now, to 2017, which was the last time a major guideline was put out in the United States. And the points along the way represent different trials on the x-axis, and the dots in the middle of the graph represent different guideline recommendations over time. You can see here that the lines do move. We don't have the same blood pressure goal that we did at the time of FDR or Kennedy or Lyndon Johnson. We have a lower blood pressure goal now, and that blood pressure just recently dipped in 2017. So the table that I showed on the prior slide of our level of what is considered controlled blood pressure, that table has changed just in the last 2 years. So 130 over 80 is going to be the number that I want you all to remember at the end of this hour. So next slide. So how do we measure this blood pressure? Because it matters, and it matters for long-term sequelae of hypertension. So what's shown here is a slide that I have purposely not made it legible. This is a slide that is taken from the guidelines. This is a table in the American Heart Association and American College of Cardiology, as well as several other societies that got together and put out guideline recommendations in November of 2017. And this table represents all of the things that should happen in order to prepare a patient for measuring the blood pressure. So these things relate to sitting down, being calm, avoiding certain medications and or habits, coffee, cigarettes, etc., prior to measuring the blood pressure and repeating that blood pressure and coming up with a number. Because this number, as we covered, is very important. And so getting to this number, the measurement should be as accurate as possible. I can probably count on one hand how many of you probably have gone through blood pressure done this way, as opposed to probably either how you arrived at Hoover Pavilion today or how you typically would arrive at a doctor's office, which is you have to park and run in and be accosted by someone at the front desk, and then probably had your blood pressure measured not in a quiet room, but in the hallway, probably simultaneously when the thermometer was in your mouth and you were getting your pulse read and asked about your medications and saw people going down the hallway. It's not typically done in the manner that this table represents, but I think we have to have a standard, and this table represents what that standard is. So it's important to know that blood pressure is not all that accurately measured in the large majority of cases in typical routine clinical practice, which in some regards is a travesty, right? This is an important number. This is a vital sign, and yet it's not altogether measured that accurately. One of the things that we did at Stanford, and this paper was published about 2 or 3 days ago by one of the Stanford medical students and colleagues of mine, that represents a way of measuring blood pressure that has been introduced in recent years to possibly level the playing field, as it were. So on this graph is a comparison of 2 measures, and one of them is routine clinical blood pressure, as I sort of illustrated earlier, and the other is something called AOBP. So that stands for automated oscillometric blood pressure. And it's not, the abbreviation is not so important, but the concept is probably more important. The concept is that one sits in a quiet room, has a cuff placed on them by a professional, and then a button is hit on the machine. And that's a countdown for about 5 minutes. So no blood pressure is taken for 5 minutes. Then blood pressure is taken about a minute apart, 3 times, and then averaged. So that doesn't require a machine, but that is not typically the way blood pressure is measured in clinical practice. But when you measure blood pressure this way, it's important because in many clinical studies, which are used to inform the clinical guidelines that we have, blood pressure is measured in this standardized way. So we are really comparing, in reality, we are comparing apples and oranges when you have a blood pressure in clinic, if that blood pressure is used to dictate your care, compared to what is done in a clinical trial that was used to figure out what the blood pressure targets should be. So on this graph, on the x-axis, is an average of routine clinical blood pressure and blood pressure done sitting down and resting, or AOB, done with by AOBP. And on the y-axis is the delta between those 2 measurements. So this is about 200, 250 measurements in various patients here at Stanford over about a year at our specialty hypertension practice. And the first thing you'll notice is that at any one level of blood pressure, so first, patients come in with very different levels of blood pressure. There are some patients that come into clinic with a blood pressure, a systolic blood pressure of about 130, and there are other patients that come into clinic with a systolic blood pressure as high as 180 or 190 millimeters of mercury. The second thing, that's okay. The second thing you'll notice is that at any one level of blood pressure, the difference between a standardized, automated, rested blood pressure is very different and can be very different than the routine clinical blood pressure. So on average, and the middle line indicates the average, the routine clinical blood pressure is about 10 millimeters of mercury higher than the automated wait 5 minutes, systolic blood pressure. So that means that if your blood pressure were 125 by routine clinical measurement, that on average in this study, the blood pressure by an automated cuff after 5 minutes was about 115 millimeters of mercury. But that is an average over all 200 to 250 patients. For each individual patient, and on this graph, a dot refers to an individual patient, the number could vary widely. So you could have a blood pressure that was 20, 30 points higher if you rested, or was exactly the same as if you did or did not rest, or was 40, 50 points lower if you rested. So it's not really possible to take all of routine clinical practice and just subtract 10. You have to actually measure blood pressure in a routine, in a standardized, automated, rested way in order to generate that rested blood pressure, to quote-unquote level the playing field. And in this study in particular, when we looked at patients that were above 130 over 80, in other words, they were not at a target blood pressure by national guidelines, about 25% of those people, so 1 in 4, had a blood pressure that was lower than the target if you used a rested blood pressure or an AOBP blood pressure. In other words, if we relied on the routine clinical blood pressure, we would be over-treating about 1 in 4 patients, which over-treating of blood pressure also has consequences. Patients will fall, patients will have side effects from drugs. These things matter also. So consequences of too high a blood pressure matter, and consequences of too low a blood pressure also matter. So one of the guideline recommendations is to measure blood pressure after 5 minutes of rest, along with some other parameters. But that's probably the most important factor, to be honest. And that matters for clinical care. And if you look at some of those long-term sequelae that we mentioned earlier, so heart attack, stroke, heart failure, kidney disease, they track a lot better with a rested blood pressure or an AOBP measurement than they do with the routine clinical blood pressure, for the reason that this graph illustrates, that the routine clinical blood pressure is not so accurate. There's a lot that comes into that, whether someone's walking down the hall, whether you're talking at the same time, whether you're late, whether you're running in for practice, or maybe you're not. Maybe you're completely calm and your routine clinical blood pressure is exactly what your rested blood pressure would be. So this really helps level the playing field and is something that is recommended by national guidelines.
How do you factor in the realistic daily activities, the spikes, the stresses, etc., versus the relaxed measurements?
Yeah. So for the audience at home, the question is how does one factor in out-of-office activities related to the blood pressure? And I will get to that in the second part of the talk, because the reality is that it's not factored in as systematically currently as we would want, but it does matter for outcomes. It matters for long-term sequelae of high blood pressure. So I'll get to that in the second part of the talk. If you don't mind, I think I want to save the rest of the questions for. Thank you, though. So, since hypertension is a condition, which is a term that I paused before I said, because high blood pressure is thought of in many ways. I'm calling it a condition. Some people call it a disease. Some people call it an indication. But it's not always thought the same. And it's taken care of by a lot of different professionals. So I'm a kidney doctor, and I take care of people with high blood pressure. But you're going to find primary care physicians, family practice physicians, obstetricians, cardiologists, nephrologists, endocrinologists, neurologists. There's such a breadth of specialties that have some domain that affects or is affected by high blood pressure. So a lot of different doctors take care of high blood pressure. And so one approaches it differently depending on the specialty that one's from. That's just a fact. And what I'd like to do right now is just approach it from the idea that this is a disease in and of itself. And if it's a disease in and of itself, it has a cause, and it has risk factors for how you'd get it. And those things matter. because controlling this disease, as we mentioned earlier, can prevent long-term sequelae of high blood pressure. So the pie chart shown here refers to the general population of patients with hypertension in terms of cause. So there is a sliver of patients that have what we call secondary hypertension. And that term comes because the majority of patients have primary hypertension. And primary hypertension has other names too, probably which are much more familiar to you. One is essential hypertension, which I think is a horrible name because there's nothing essential about having high blood pressure. Or idiopathic blood pressure, which is probably a more accurate term because we really don't know the cause of everybody with high blood pressure. And we can guess pretty good, but we don't actually do that many tests to figure out what is the cause of high blood pressure because it's so common. And most of the time, we can't pinpoint it, so we don't spend that much time doing tests and trying to figure out the cause, which is astounding if you think about it. There's not very many specialties or conditions or diseases in medical practice where one doesn't bother to figure out why you have it. And this one affects 1/3 of the United States population and half of everybody over 65. And we just kind of chalk it up to just general bad luck, and it's common. And so part of trying to figure out what the causes are is something that will, I think, occupy the minds of hypertensionologists as we go forward. But for the time being, about 95% don't have an identifiable cause and have what we would call primary idiopathic or essential hypertension. And about 5% will have a secondary or identifiable cause of hypertension. So even though we don't know the cause of patients with hypertension, we do have a sense of what adds gasoline to the fire. So what are the things that can exacerbate high blood pressure and can potentially take someone who needs 1, 2, or 3 medications, and if you eliminate these exacerbating factors, can bring them down in terms of the number of medications they need, or in some cases can actually bring them below the target level to the point that they don't need medication, or to the point that their blood pressure is normal. So this is part cause, but mostly we think of these as exacerbating factors. And these are the common ones. Yes, sir.
There was a study that came out last week of 14,000 people over a 10-year period, and they said that salt had no effect on heart blood pressure in the long run.
So the question relates to sodium, and I have dietary sodium listed here as an exacerbating factor. Let me address that when I get to that in just a moment. So one of the most common causes of high blood pressure is obesity. And when I say common, I mean about 70 to 80% of patients with obesity have hypertension. It is astoundingly common. Equally important with regard to that risk factor is weight loss. To take care of that obesity helps to reduce blood pressure. So this is a big part of what we call the diet and lifestyle measures that we employ and talk to patients about with hypertension or even pre-hypertension. Patients that don't have normal blood pressure but don't yet have stage 1 hypertension. A second one is a lack of exercise or a sedentary lifestyle. And this is one that also the flip side of that coin is true. In other words, if this is identified as a factor for high blood pressure, increasing exercise or decreasing a sedentary lifestyle will help to reduce the blood pressure. The third of these is something that is not altogether commonly tested for, but is really common in patients with severe hypertension, which is obstructive sleep apnea. Can I get a show of hands for those in the audience that have heard of obstructive sleep apnea or OSA? Great. That makes me, I'm happy because it's really important that message gets out. For those of you who haven't heard of this, obstructive sleep apnea refers to the idea that one stops breathing due to an obstruction in the airway. And this is the purview of both pulmonologists and sleep medicine physicians who can test for this and can treat this. I should say also ears, nose, and throat physicians can treat this too. And the worse your blood pressure, the more this helps to get identified and treated. So without getting too much into this, one of the things that we try to do in a hypertension specialty practice is to ask about this, query this, and test for this if we suspect it, because it really can make a difference in bringing down blood pressure. More so if you have severe high blood pressure than if you are chugging along at a blood pressure of 131/81, where you're just barely over the line. It matters a lot more if your blood pressure is much higher. The next point is diet, which is probably the one we as hypertension physicians get asked about the most, because it's one that people can most easily influence in their daily life. And I've written down here high sodium diet. And when I say high sodium diet, there are many ways to define that. According to the United States recommended daily allowance, you want to have less than 2 grams of sodium in the diet. And this refers to sodium, not sodium chloride or table salt. So the numbers can sometimes be difficult to convert. But on the label, the nutrition label of any purchased food item, it's written in milligrams for sodium. So if those numbers total to less than 2,000 or less than 2,300, which I've written out here, that would be considered a standard to low sodium diet. The average sodium diet is probably double or near triple that for the average American. So it is a major part. The way that this gets asked about in clinical practice varies widely. This can be something that you may see a dietitian for. This can be something that physicians will ask if you add salt to your cooking, or to you have table salt to add to your food. Sometimes it's asked in the form of how often do you eat out, because that's a pretty good proxy in my experience as to how often you're getting sodium, because food that's eaten out typically is flavored with a lot of sodium. Another way that we have tried to gauge sodium if we don't feel that we have a reliable history, or if something's not fitting in the picture quite clearly, is we'll do a standardized steady state urine collection to quantify the amount of sodium in 24 hours. And while this is not completely accurate all the time, and probably the more data the better, it does give us a little bit better window into the amount of sodium in one's diet. There are a variety of studies that say that a high sodium diet can lead to worsened blood pressure. There are a variety of studies that say that a high sodium diet can lead to bad outcomes of hypertension, so long-term sequelae of hypertension, such as heart disease and kidney disease. There are other studies that will actually say that sodium does not matter for long-term outcomes, as the gentleman here referred to. It's a hotly debated topic, but some of the data that I believe you're referring to, I'm not completely certain of the study, but I believe you're referring to, does take into account a number of patients that don't yet have high blood pressure, so not everybody's an incident high blood pressure patient. In most studies where you're talking about patients that already have high blood pressure, lowering the sodium in the diet can help substantially. It is not immune from the same rule that applies to everything on this list, which is that it varies per person. So if you have obesity and you have high blood pressure, in one patient or one individual, a loss of 10 kilograms will have a profound effect on blood pressure, whereas in another individual it might only have a small effect. The same goes for exercise. The same goes for obstructive sleep apnea. The same goes for lowering of sodium in the diet. So everybody varies. And the factors that cause people to vary are part environmental and part genetic. But it's important to know that most of these things in most studies have met the bar of getting into guideline practice and have stood the test of time, especially in patients who already have high blood pressure. when you're talking about individuals that don't yet have high blood pressure, and you're looking at whether these measures will prevent bad things that are related to hypertension, such as heart attack, stroke, and kidney failure, it's not so clear. But in patients that already have high blood pressure, the data is fairly clear. The last comment I have here is on drugs. So these refer to both benign and not so benign forms of drugs. Probably the one that I've listed here that I find the most useful to query about in clinical practice are pain medications. So non-steroidal anti-inflammatory drugs, or NSAIDs, which include things like Motrin, ibuprofen, Aleve, naproxen. These are medications that when taken chronically, not just for a week if you have an orthopedic injury, but when taken routinely and chronically, can exacerbate high blood pressure. And we look for these for a variety of reasons, but we look for them in kidney clinic and in hypertension clinic. The other things on those lists can oftentimes influence the blood pressure in the here and now. So things like tobacco can raise your blood pressure. Illicit drugs such as cocaine and amphetamines can raise your blood pressure acutely. Nasal decongestants like Sudafed can raise your blood pressure acutely. So we ask about these things, particularly if somebody has a very high blood pressure in clinic, and you're assessing whether that is part of their routine blood pressure that they have at home and in clinic, or it's just at that particular time. Yes, sir.
Why do doctors prescribe aspirin then to lower your blood pressure?
So the question is, why would we prescribe aspirin to lower the blood pressure if aspirin is on this list of analgesics? And the answer is that aspirin is an exception to that rule. Aspirin is an exception to the rule. It has some of the side effects of non-steroidal anti-inflammatory drugs, but doesn't appreciably raise the blood pressure, and it has so many other salient benefits that it is something that we often recommend. It is not specifically recommended to lower blood pressure, though, but it is, at least according to guideline practice, it is given to many patients who also have hypertension, because it is given for conditions that are commonly associated with hypertension or are caused by hypertension, such as heart attack, heart failure, and other cardiac abnormalities. And so peripheral arterial disease, carotid disease. So that's why patients that take aspirin and have hypertension often could associate the two, but it is usually not given for hypertension specifically.
So is Tylenol also an exception?
So Tylenol is an exception to this rule. Narcotic medication is also an exception to this rule. If you don't mind, we can do more of the questions at the end. But this is terrific. I'm glad you guys have a lot of questions. So this slide is another pie chart of a breakdown of primary idiopathic essential hypertension versus secondary hypertension. In the first slide, we had a 95% to 5% ratio. And here I'm showing a much larger piece of the pie associated with secondary hypertension. And so what this pie chart refers to are those patients that have severe hypertension. And I haven't given you the definition yet of severe hypertension, but it generally refers to patients who take their medication and take several medications, as many as 3 or 4 medications or more. So different classes of antihypertensive drugs. And they, despite that, still have elevated blood pressure. They try to address the risk factors that we went over on the prior slide, and despite that, have high blood pressure. They're compliant with their medication, and despite that, they have high blood pressure. And so in this group, this represents about 1/5 of all patients with high blood pressure. So that means 80% of patients with high blood pressure don't have severe hypertension, but 20% of them do. And if 1/3 of the people in the country, or 100 million people, have high blood pressure, 20% of 100 million is a big number. So this is commonly encountered in clinical practice. And because of the notion that they have a 5-fold higher chance of having a demonstrable cause of their high blood pressure, this is the population that might get special screening tests for high blood pressure. Why do they have high blood pressure? Let's see if there's a specific cause that we can target and treat, rather than giving a blanket therapy that would apply to anybody with essential hypertension. So that's why I put up this graph. This does not apply to everybody. If you walked into a clinic with a blood pressure of 135/85 and you were 59 years young, you would probably not get a whole bevy of tests and ultrasounds and MRIs and things like that. But if you have severe hypertension and you've bounced from doctor to doctor to doctor and nothing is controlling your blood pressure and it's been years, you might encounter a physician that would send a number of different tests looking for different secondary causes of high blood pressure. I don't want to get into this because in the entire hypertensive population, it's still only about 5%. But there are lots of different causes that come under this umbrella. And so if you have high blood pressure and you're getting tests done to elicit a cause of that high blood pressure, your physician is probably looking for the things on this list. Some of these things are much more common than others. Some of them are extremely rare. And I don't, for the sake of time, have time to get into all of these things. But there are things that we do know that cause blood pressure that we can either identify as a specific cause or treat as a specific cause. So in certain patients, we will look for them. Those certain patients include patients with severe high blood pressure. They also include patients that are 25 and have high blood pressure, so very young and yet have high blood pressure, because that's not a common age to develop high blood pressure. Or 85, because that's also not a common age to develop high blood pressure all of a sudden. So there are different instances where we might look for high blood pressure causes, and there are many more instances where we might go ahead and start treatment from the get-go. So just to give you that distinction of what we know now, that's part of clinical practice. Oh, we're running out of time. So I'm going to go a little bit quicker through this because this is data, and the bottom line of this data is probably more important to get to. So this is a picture of the article title from an article that came out in 2015, about 4 years ago, in the New England Journal of Medicine, which is a preeminent medical journal. And it's entitled A Randomized Trial of Intensive versus Standard Blood Pressure Control. And this reported on the results of a study called the SPRINT study, which was an acronym that referred to Systolic Blood Pressure Intervention Trial. I'm drilling down a bit on this particular study because this heavily influenced the current guidelines, which were revised in 2017. So this was a study that involved over 9,000 individuals. And the study was designed to ask one particular question. At the time this study was designed, the goal blood pressure was less than 140 millimeters of mercury for the systolic blood pressure. And it had been known for a long time that perhaps we need a better trial to see how low we should go. So maybe the goal blood pressure should be as low as 120 millimeters of mercury. So this trial had patients enroll, and they flipped a coin and had patients either be in the group that used enough medication to get down to a blood pressure of 120 or less, and the other group get down to 140, as was convention at the time, and followed them and saw whether they developed the long-term sequelae of high blood pressure in the form of heart attack, stroke, death. And this trial was particularly important because it involved and was enriched for cohorts of individuals that don't get enrolled in all the blood pressure trials and have been involved in smaller trials before that. But this was meant to be the largest enrollment of a number of different subgroups of patients, including the elderly, including patients with prior cardiovascular disease, so patients that already had sequelae of high blood pressure or were at high risk of having events from high blood pressure, and also patients with chronic kidney disease. And the punchline is that the trial ended early. Big New York Times article, made the lay press. The safety monitoring board realized that the patients that had a blood pressure less than 120 were having so many fewer events than the patients that were targeted at just under 140 that it was not ethically possible to continue the trial. They had to stop and report the findings. So about a quarter, there was about a 25% reduction of the risk of having a heart attack or stroke or death in the group that was less than 120 versus 140. And there were more events that are associated with low blood pressure in the group that got down to 120, as you might imagine. But the overall mortality was improved if you had a lower blood pressure than if you had the higher convention at the time target. And when they tried to see if there was one cohort of the patients that was really driving this result and heavily influencing the average, there wasn't. This referred across the board to different subgroups. And every time the average fell on the side of lower is better. And that's why these boxes are on the left side of that vertical bar. So that heavily influenced the American Heart Association, American College of Cardiology guidelines. And these guidelines were put together by a team of experts, including folks from here at Stanford. And they asked several questions. They asked what should be our blood pressure target, how low should we go? They asked which antihypertensive medications should be used in particular populations, and which pattern of antihypertensive medications should be used. Should we start one medication and then ramp up the dose until we're at the maximum dose, and only then and only then add a second medication? Or should we start with a low dose of one type of medication and then add a low dose of a second type of medication if patients don't have control? And then the last question is there evidence for self-directed monitoring for better outcomes? Putting it another way, if you check your blood pressure at home, do you do better? Which is really the topic of the second part of the talk. Donna, can I ask a question? If we go slightly over, is that if we go slightly over, is that okay?
Yeah, absolutely.
Would you all be okay if we went slightly? Okay. I apologize for those of you who have to get back to the game, but I can assure you it's affecting me as well. So this is a flow chart that was part of those guidelines. And so this is not a straight line. So there are factors that matter when your physician or your advanced practice provider or your care provider is trying to determine what blood pressure you should be at and what's the proper target and how to get there. And so this all distills down into that chart that I showed earlier, that if your blood pressure is less than 120 over 80, that's normal and there's nothing to do. If your blood pressure is greater than 140 over 90, or stage 2 hypertension, that's easy. You got to start medication. The rub comes in between. What do you do if you're in between those areas? So if you're between 120 to 130 on the top number side, we considered that pre-hypertension. And it's not quite normal, but it's less than 130. And that is the domain under which we provide a lot of guidance on diet and lifestyle measures. Things like controlling weight, increasing exercise, lowering sodium in the diet, asking about risk factors. That is the sphere under which those things will still make a difference. If your blood pressure is greater than 130, or even greater than 140 or 150, 160, we still employ those measures. But when the blood pressure is higher, we have to use medication kind of from the outset, depending on how high the blood pressure. So the biggest and most complicated part of this table, or this flow chart, and the most controversial part, came when you had a top number that was between 130 and 139. So this is, if you'll remember, the goal prior to SPRINT, prior to that systolic intervention trial being published, the goal was to get a blood pressure less than 140. And here we are, your blood pressure is 135. What do? Do you go by that SPRINT trial that just came out that was stopped early in the New York Times? Or do you go by the tried and true convention from before that said, you're less than 140, nothing to see here, nothing to do here, go about your day? And the answer that the guideline committee and the writing committee settled on was that it kind of depends on how at risk you are. So if you're between 130 and 140, then one uses a atherosclerotic cardiovascular disease risk score to determine how at risk you are from consequences of high blood pressure, things like heart attack and stroke. And so the things that come into that equation involve age, they involve other factors such as cholesterol. And a risk score can be calculated by your physician in about 3 seconds using an app, using Epic, going on the internet. All of you can do it too. It's very simple. But if that score exceeded a certain value, then it was considered prudent to start medication. And if you were not at risk at all, and your blood pressure was greater than 130, then it was considered safe to employ the standard fare of diet and lifestyle changes. No need for medication just yet. So it's a complicated system, but overall, our goal is to get a blood pressure less than 130/80. How you do that kind of depends on how at risk you are, whether you can use diet and lifestyle measures, or whether you also have to use medication. In some patients, it's pretty simple. In other patients, it's a bit more controversial. So the summary of the guidelines was that, and this was in contrast to prior guidelines in prior generations, which was that there was a different number for different groups of patients. If you were 85 years old, you had one number. If you had chronic kidney disease and diabetes, you had a different number, and it made it very confusing. So one of the goals of the writing committee was to try to make this as simple as possible and back up what they said by as much data as they could. So for the general population, a goal of less than 130/80 is still considered that guideline recommendation. That was the same if you were less than 60 or greater than 60. That was the same if you had kidney disease or didn't have kidney disease. That was the same if you had diabetes or didn't have diabetes. That last point is a bit controversial because this study didn't include diabetics on purpose. But based on other studies, which I didn't have time to get into, and based on other analyses since SPRINT was discontinued, this guideline was felt to be appropriate for patients with diabetes as well. This is a quote that applies to the guidelines but wasn't part of the guidelines, which is that the use of any drugs that reduce blood pressure to help protect patients from strokes or other serious events is more likely to help than giving patients no drug at all. So I think this is generally a true statement. Certainly if your blood pressure is 115/75, you don't need any drugs at all. But I try to go by the adage that the higher your blood pressure is, the more benefit you're going to get from medication and the less likely you're going to do harm. And so also, the type of medication to use is probably less important than the use of medication at all. And that every group probably benefits from some blood pressure control. Some groups may benefit from a particular type of medicine more than a different medicine, but they benefit from some medicine versus no medicine at all. So while I don't have time in this hour to go over the specific types of antihypertensive medications, we have time for that in the question period, but some medicine is better than none. So for the second part, I wanted to discuss the future and what we know now, and I've changed my symbol to a smartwatch to reflect this. So I alluded to this earlier when we talked about high blood pressure, and one of the questions from the gentleman on the left was, what about all the stuff that happens at home and how the blood pressure is at home? And the title of this slide is Out-of-Office Blood Pressure is More Strongly Associated with Risk Than Routine In-Clinic Blood Pressure. And that is true. So what's shown on this graph, and as I populate it, is the y-axis is the 2-year cardiovascular risk, and on the x-axis is the systolic blood pressure. And this is sort of the risk for routine in-clinic blood pressure. This is taken from a study from 1999, but it applies just as well now. Compared to daytime blood pressure that's measured with either a monitor that's affixed to you all day or measured, routinely and periodically throughout the day, versus the 24-hour average blood pressure, which incorporates blood pressure from the nighttime as well. But look at this last one. This last dotted line is nocturnal blood pressure. So this tells me that the nocturnal blood pressure, the blood pressure we aren't measuring all that often now, is the one that matters the most for cardiovascular risk. So in terms of home and office, there's really kind of 4 categories of hypertension that one could have. So I've got a 2x2 table that we're going to fill in with boxes here. And on the x-axis is going to be 2 camps of either normal blood pressure at home or high blood pressure at home. And on the y-axis is 2 camps of either normal blood pressure in clinic or high blood pressure in clinic. So the first box is probably the most self-explanatory. It's normotension, or normal blood pressure. When you're normal in clinic and normal at home, you're normal all the time, nothing to do. And the last box on the bottom right is also probably the simplest to think about, which is sustained hypertension. So this is blood pressure that's high in clinic and high at home. And when I say high at home, I mean during the day, at night, one or both. This box in the bottom left, high blood pressure in clinic and normal blood pressure at home. This is oftentimes referred to as white coat hypertension because patients may respond with either stress or some other unidentified factor and having high blood pressure in clinic, but yet, doc, when I'm at home, my blood pressure is totally fine. That blood pressure you've got is inaccurate. I'm fine at home. What do I do? And so that's that box. And the last box here is probably the one that's the least intuitive, which is the blood pressure is normal in clinic, and yet the blood pressure readings at home are quite high. And this is referred to as masked hypertension. So that term was first coined by Dr. Pickering in 2002, but it gets about a sentence and a half in the national guidelines today. Yet, if you measure the percentage of patients that have each of these, it's a little bit less than 10% of patients all told that will have masked hypertension, 8.4%. So this data is taken from about 63,000 patients in Spain that got blood pressure measured in clinic and also had a 24-hour ambulatory blood pressure monitor affixed to their upper arm to get readings during the day and at night and just generally at home. What's shown here is the all-cause mortality when you look at the different buckets here. And masked hypertension had a higher mortality risk than sustained hypertension. So that means that if you're high at clinic and high at home, you were better off than if you were fine in clinic and high at home, which is astounding and is the least diagnosed thing, because unless you're measuring blood pressure at home, you would never know, you would never unmask that you have masked hypertension. So this is both common and consequential and currently not diagnosed that much. So I put it in this part of the talk because it's what we need to know going forward. So how are we gonna assess for masked hypertension? So I have some pictures later on, but I think one of the ways that this is going to come to fruition is with wearable technology, and things like a smartwatch can measure a lot of things, and things that are affixed to the patient or the individual is a huge industry. It's predicted to be a $100 billion industry by 2024 and probably $150 billion by 2027. So whether you have a smart shirt or a smart watch or anywhere in between, that all is considered wearables. And for healthcare wearables, there's really 3 categories that this fits into. These are things that are part of just information gathering for information gathering's sake. The term that is used for this is called infotainment, so entertainment based on information. It's also going to be useful going forward for things like precision medicine, which is a term that the medical school dean uses a lot here when talking about the future of healthcare. and also for precision trials where we can track data much more precisely for measuring outcomes. And currently, there's a lot of things that we can measure by current devices. We can measure dietary intake by either taking a picture of a piece of food or a package, coded number, or just typing in a calorie count. We can measure body weight by a scale that can automatically Bluetooth the weight to your phone and then to your doctor. We can measure other vital signs. We can measure temperature, heart rate and rhythm. The Apple Watch, version 4 that just came out this year, actually can measure the equivalent of an EKG lead and can detect atrial fibrillation as approved by the FDA, which means that there's a lot more data going to physicians and researchers now than there ever was. We can even measure respiratory rate and even properties of sleep through a smartwatch. We can measure activity, certainly, and anybody here who has a Fitbit or an Apple Watch or anything in between can measure activity. We can get genetic data that can be incorporated into the assessment of the other terms here. And in the future, hopefully, we'll have wearable blood pressure. Why does this matter? So why would we care? We would care for the reason that I showed on the prior slide, that blood pressure at home matters. Nocturnal blood pressure matters. And yet, even if we measure blood pressure at home on a piece of paper and we write it down once a day or twice a day, that's a burden on the patient. It's not uniformly done across all individuals. Some people rest before they measure their blood pressure, some people don't. Some people take it in the morning, some people take it at night, some people take both, some people take it at 12 o'clock. Some people take it 2 or 3 times and then average it. Some people do it for a week and then don't do it at all. It's completely arbitrary, the data that we get. And we don't have standardized home blood pressure. There is a way to measure it, like in the Spanish study, where you can wear a cuff for 24 hours. But that's certainly not going to be something that most people wear all day, every day for a month. And one of the questions that has come up is, how often do we need to do this? Let's say you had a device that could measure your blood pressure. Let's say it was a watch that could measure your blood pressure, or a wrist device of some sort. What does matter, by a couple of different studies, is that the higher frequency of blood pressure monitoring does alter both the precision and the accuracy. And that's important, because more precise data intuitively is not necessarily that important, but more accurate data is definitely important. And it's because currently the way we take care of hypertension is we go by targets. And if the blood pressure device that one has is more accurate by getting more measures, then you're likely to not overtreat or undertreat, for the same reason that if you use arrested blood pressure with an AOBP device, you are less likely to be inaccurate in terms of the blood pressure that matters compared to the routine clinical blood pressure. So how would we do this? The graph on the left is probably the most common way that most people do it. They have a home blood pressure cuff, which many people in the audience said that they did. I suspect most of you have an upper arm cuff as opposed to a wrist cuff, and you write down blood pressure, or it's Bluetooth to your phone, or you type it into an iPhone, or you keep a log. But it's usually different from patient to patient. Some people bring in Excel spreadsheets with averages calculated and nice smoothed out graphs over months. Not everybody does that. And it's not completely clear that that's more helpful. But other people will do a 24-hour ambulatory blood pressure, where your physician or your care provider gets a report, such as shown on the right, where we have a reading over the 24 hours, and we know what percentage of the time you're over target and what percentage of the time you're under target. And depending on the smartness of the cuff and the engagement of the user, you actually have information about what one was doing at the time that the blood pressures were being measured. So exercising, walking, etc. And this can measure blood pressure during the day, blood pressure at night, etc. So the device on the right is probably the standard of care for measuring nocturnal blood pressure currently. But kind of how did we get here? So the first recorded measurement of blood pressure really happened in the 1700s in a book called Hemostatics. And soon after that, a manometer was developed by the gentleman who came up with Poiseuille's law. And then the sphygmomanometer was invented in 1881. The one that you all have now isn't that different from the one that was from then. We're in need of a change. In 1905, Dr. Korotkov coined the term for the sounds, the Korotkov sounds. That's important because that's what your care provider uses to measure your blood pressure if they're using a handheld device and listening with a stethoscope to get the systolic and the blood pressure, the diastolic blood pressure. Then in the 1990s, oscillometric home and office devices became much more common. These are probably the type that you have at home if you don't have a mercury manometer or an aneroid cuff. And they are often, they have sort of replaced a mercury cuff for standard practice. And they're fairly accurate. But kind of what does the new wave look like? If we get into how we would measure blood pressure often and during the day and at night, we know that we need to. This idea of masked hypertension has been around about 17 years. In 2015, which was kind of the year of hypertension, if you think about it, this is the year that the SPRINT trial was published. This is also the year that the U.S. government put out a recommendation that if you have high blood pressure in clinic, that it was going to reimburse for doing a 24-hour ambulatory blood pressure at home in order to formally diagnose hypertension. Not to give it to a patient that already has hypertension to make sure that their blood pressure at home is accurate and doesn't have masked hypertension. It was just used to kind of look at white coat hypertension. And that's an important distinction. Then in 2017, these guidelines that I was referring to came out. And the idea of using an ambulatory blood pressure monitor was not wholly endorsed for patients with existing hypertension, but it was considered expert opinion that it's a good idea in cases where you're unsure. And then last year, the Center for Medicare and Medicaid Services actually asked the medical community to comment on the idea of using an ambulatory blood pressure monitor more often. Maybe we should be reimbursing for this. Maybe this is important. Maybe measuring blood pressure at home and diagnosing masked hypertension should matter. So I'm proud to say that the Center for Medicare and Medicaid Services was listening. Many hypertension experts around the country commented on this and provided either data or references or expert opinion that it should be considered more often. And there's some current changes that have been proposed, which I think are still in the works. But it looks like soon enough an ambulatory blood pressure monitor may be available, certainly more likely than it has in the past. And so we'll have to see what happens next year. This is a slide of novel blood pressure devices that are not yet on the market. And I put this up just to give you guys a sense that there are companies that are working on this. There are all different kinds of blood pressure devices that may be a blood pressure cuff on the finger or on the wrist, or even blood pressure without a cuff, using a different form of measuring pressure and pulse wave velocity to assess what the blood pressure is, or using the back of an iPhone, as Samsung has on the back of their iPhone. There's a way to measure blood pressure, or using other techniques. And each of these has their pluses and minuses, and some of them have been endorsed by the FDA, but they're out there. There are different ways of measuring blood pressure. I've shown a picture here of kind of some of them. There is something called the Omron Heart Guide, which is actually a watch that was approved by the FDA. I will stop and say that I don't work for Omron at all, and I haven't not seen their validation data. But this watch is available for public purchase. I wouldn't caution everybody to go out and buy one, nor do I think it's going to be bought by consumers all that often. But the idea that there is a watch that has a cuff as the wristband that can measure blood pressure and that is purported to be accurate is an advancement compared to the 1881 technique that we've been using for all this time. There are other blood pressure devices. The one at the top right is the only one that's actually not a cuff-based blood pressure that is endorsed by the European Society of Hypertension, which is one of the validating bodies. None of you would probably be caught dead wearing this device for more than a few minutes, but it is a way to measure blood pressure without a cuff. But you have to be at rest, which is an advantage for nocturnal blood pressure, not an advantage for going to Trader Joe's, though. And the data on the bottom right is just a different technique, which comes from the company that I help advise, and so I don't want to say any more about that at this time. I think with all of these new devices, it's really, really important to take caution. And probably 5 years from now, there'll be way more ways of measuring blood pressure than there are now, and they will all be validated and endorsed and be familiar to your care provider. But right now, I would not say that that's the case. And validation is absolutely critical. What's shown here is a study out of cardiovascular medicine here at Stanford, which looked at a variety of different wearables, looking at heart rate and energy expenditure. So how many calories are you burning? Or what's your heart rate? And so these were things like Fitbits, Apple Watches, a number of other different types of devices. And they took about 65 patients and had them run on the treadmill. They had them get their heart rate up and down, measured energy expenditure in different scenarios, and then used the gold standard to compare. And for the heart rate, the devices were pretty good. The error rate, which is shown here by the yellow bars, to the left is that one device is off compared to the gold standard, and to the right is vice versa. But look at energy expenditure. The error bars are huge. This smacks of inaccuracy and the need for validation, and the same is true for blood pressure. In 2017, there was an app called, I believe it was called Instant Blood Pressure. There was a company that is defunct now, but advertised that their blood pressure device accurately measured blood pressure. And it was a device that seems like voodoo now, which was that one was instructed to hold the device up to the breastbone and wait a few minutes after you push a button on the machine, and then a blood pressure would show up on that device. And colleagues at Johns Hopkins decided to validate that device and found that it was inaccurate about 80% of the time. But it had thousands and thousands of downloads by that time. And it took an article in a major publication to cause the downfall of that device, but not before, I'm sure, some patients had purchased the application, and God forbid they actually used it to influence their care. Yet it was 80% inaccurate. So validation is critical for all of these new devices. So I will leave you with the idea that multiple modalities are under development. There are ongoing issues with all of them. The rest versus motion artifact is a big one. The form matters. We know that patients are not going to wear something all the time if it's clunky, right? And how often a patient needs to actually interface with the device versus something that just passively measures your blood pressure matters a whole lot. There are lots of examples of applications that can input all sorts of data to your device and then transmit it to your healthcare provider. But if you have to be typing constantly all day, you're unlikely to continue it in the long term. So patient engagement matters. And I can't emphasize enough how much validation matters and will improve the synergy between patients and providers, provided that it's accurate. So I'd like to end there with sort of what we know now and what we ought to know in the future, and take any questions. Thank you for listening. Yes, I'm going to start with the gentleman in the back.
Beta blockers lower adrenaline. How do they lower adrenaline?
So the question is, beta blockers lower adrenaline, and how do they lower adrenaline? The answer is that they don't really lower adrenaline, but they lower the effect of adrenaline. So beta blockers, and depending on the type, can block the receptor which adrenaline or other hormones similar to adrenaline act. And so that's how they would lower the effect of adrenaline rather than the actual level of the adrenaline itself. Yes, sir.
You emphasized the number 130/80, but then you showed this picture of a continuous monitor. During the day it goes up, sometimes it goes down.
Yes.
Is there any guidance about how often it should be above, how often it can be below, what happens during the day? I mean, it's very confusing.
Yes. So the question has to do with what do we do with the pattern of out-of-office blood pressure relative to this one number that we're supposed to hang our hat on. And the answer is that there are guidelines on what is the average for the 24-hour that we should be following. What is the average? What is the equivalent risk average for the in-clinic blood pressure of 130/80 when you're looking and assessing at the 24-hour versus just the daytime versus the nighttime? So there are parameters that are the equivalent for that. They're not exactly 130/80. So the nighttime blood pressure has to be lower than 130/80. The daytime blood pressure most of the time also has to be a little bit lower than 130/80, and the 24 hours kind of part of daytime and part nighttime. But there are equivalents, and I didn't have time to get into those numbers. But when you do a 24-hour ambulatory blood pressure monitor, those equivalents are part of the report, and it's reported as such and read as such, and it should be interpreted as such by a care provider. And in the reports that come out from the companies that generate those reports, it's signified on there. I would say that the most important thing to think about for long-term consequences is what your organs see. So your organs see an average. Your organs see an average over time. And the extremes are the things that are exception to those rules. So if you have a blood pressure that is less than 130/80 all of the time, great. It's a simple interpretation. But if you have a blood pressure that's a few times during the day, greater than 140/90, but a lot of times during the day it's less than 120/80, and the average is less than 130/80, you're good. That would be considered something that would be okay. If you have a blood pressure that's 80, systolic blood pressure of 80/50, or a blood pressure that's 180/110, that's not okay. So there are acute examples at the extreme ends that matter for risk for acute events. And so it is a combination of average and looking at the data. But in general, the average matters more than some of the actual numbers. So we don't necessarily query by number of times greater than 145, for example. It's probably more accurate to query by the average over the 24 hours. And studies that have evaluated risk, long-term cardiovascular risk, go by the means. They don't go by the number of times it's less than the target out of the day. Because you could imagine if you had all this data, and an ambulatory blood pressure monitor captures data about every half an hour over a 24-hour period, so that's 48 points of data. People who measure blood pressure at home on their own measure it maybe 2 or 3 times at most, right? When we assess the risk, it's the mean over that time period that's used. It's not the percentage of the time greater than 130/80. Oftentimes those two things will track together, but then there are exceptions to the rule. Yes, ma'am.
If you're over 80, can your blood pressure be higher? And do you usually have to take less meds than you did when you were younger?
So the question is, if you're over 80 years old, or you're 81 years young, can your blood pressure be higher? And do you have to take as many medicines as when you were younger? So the answer is that according to the AHA, the American Heart Association and American College of Cardiology guidelines, we still shoot for a blood pressure less than 130/80 by guideline recommendations. But what is paramount in taking care of anybody in medicine for any condition is the individual patient. So part of that refers to the maximum tolerated medications that people can take. So if you have a blood pressure that has been 145/95 for decades, because the old guideline recommendations were that greater than, let's say 139/89, let's just say as an example, that was considered normal for years. And now we're saying less than 130/80. And your body is used to that. And then we try to shove more medicine in you and get it down to 122. with a 17 millimeter drop in blood pressure, you're probably going to feel that. And it is certainly not something that we do quickly if we're going to bring your blood pressure down. And there are cases where patients may just not feel well and may have an adverse event from bringing their blood pressure down too much. So we, if we're going to bring blood pressure down, we go slowly. And in some cases, if patients don't tolerate that or don't tolerate more medicine than what they're currently taking, we often won't give more medicine. But in some cases, if there are no risk factors to be had or no events that have happened or no effects of the medications that are adverse, and we just had the numbers to go by, we probably would slowly try to get your blood pressure down to less than that goal. There are societies other than the American Heart Association that haven't agreed with those guidelines, that don't recommend bringing the blood pressure down to less than 130/80 for elderly individuals. But that debate will continue, and each physician will adopt their own version of the guidelines and how comfortable they are with them. But there are going to be physicians that are bringing that blood pressure down, but there will also be some physicians that don't. So it really kind of depends on the individual patient. Sure. Yes, sir.
Are there statistics on something, for example, people in their 60s who have a certain higher range of blood pressure versus lower blood pressure or normal blood pressure, and what the mortality difference is?
So the question relates to statistics, mortality statistics based on age and high blood pressure. So age is...
more with a certain blood pressure range.
So are there age specific guidelines?
People in, let's say,
Yeah.
their 50s or 60s.
Yes. So the question relates to age specific guidelines for age specific blood pressure targets, rather more specifically.
No mortality rates, what I'm asking about.
So the most observational studies indicate that for the same given blood pressure, the older you are, the more at risk you are, and those curves evaluate blood pressures as low as 115 up to 185. So age is considered a risk factor for most cardiovascular diseases. There was a time that the age mattered in terms of the blood pressure target that we would get to, so it would affect therapy. The newer guidelines are there's less of that for sure, but older guidelines had a different cutoff depending on age, and it made it more.
I'm asking you something a little different from what I feel like you're addressing. If you take an arbitrary group of people in their 60s with 140 over 90 versus a group in the same age range of normal blood pressure, what is the difference in the mortality rate over a period of time?
So within an age group, how much does the blood pressure matter? So the older you are, the more the blood pressure control probably matters, I would say.
That's what I'm saying.
Yeah.
An arbitrary range, otherwise it wouldn't be an even comparison.
Right, but there are observational data that are based on age and based on blood pressure levels, and it's somewhat linear. That for any different age group, higher blood pressure is going to have a higher risk than a lower blood pressure. It may vary. The extent and the magnitude of that risk will vary with age also, and generally the older you are, the more of a magnitude it matters. So I can't give you data on the 60 to 70 age group.
Can you give us an idea? Are we talking about 1% higher mortality or 50% higher mortality?
I wouldn't say it's 1 and I wouldn't say it's 50, but it's enough to keep the same target, is what I would say. I hope that helps answer the question. Yes. Thank you. Yes, sir.
Yeah, I noticed that FDR's pulse pressure was about 100 on that chart that you had up there.
Yes.
Which I've been taught would indicate that he had bad atherosclerosis. Does that make sense to you?
Yes. So the question is about pulse pressure, which is a differential between the systolic and the diastolic blood pressure. And yes, the higher the pulse pressure, that can be a sign of a variety of different conditions, including atherosclerosis, but also including aortic valve disease, a specific type of aortic valve disease. So it can mean different things. And different physicians will put more or less stock in pulse pressure. I'm married to a cardiologist, so I can say this safely, that cardiologists look a lot more at pulse pressure than us nephrologists. And I just confessed earlier that I look at the systolic blood pressure most of the time. But it does matter for certain conditions. Yes. Yes, sir.
The question probably is more for another talk, but you really didn't give much detail on the hydraulic system that we have, as far as where the pressure comes from. And I suppose if you were a surgeon, you'd be pointing out that, certain disease in certain areas could be treated not just with drugs, but actually physically. And that does happen, doesn't it?
Yes, so the question has to do with the structural etiology of high blood pressure. So there are conditions where disease in the vessels can affect the blood pressure differently than the standard garden variety primary essential idiopathic hypertension. There's something called aortic coarctation or subclavian artery stenosis that will give a different blood pressure pattern. Those things are less common, and they are things that usually they present under specific scenarios, sometimes very young patients or very old patients or elderly patients will present with conditions such as that. We do tend to look for them, probably not as uniformly and systematically as we should, but these things come up, for example, when the blood pressure in the two arms is different and routinely different. That will give us a clue to a disease in the vessels that are in the upper part of the body. So we do look for them in specific cases. I've had patients that have said to me, "Doc, my blood pressure is always lower on the left. It's 15 millimeters of mercury lower on the left. What's going on?" And so there are certain things we do to kind of separate artifact from reality, and then what tests you would do to go from that point forward.
So there are physical things that you can do, not just drugs.
Yes, that's correct. There are also physical things that affect the arteries to the kidneys. That is a form of secondary hypertension, which I didn't have time to get into detail about, that can affect blood pressure. There are things that can affect blood pressure the other way. So baroreceptor trauma in the neck can cause low blood pressure. So there are certainly structural things that affect blood pressure. These things are not as common as essential garden variety high blood pressure, and so we don't look for them in everybody, but there are clues that we use as to when we search for these types of structural things.
Yeah, I want to make sure and compliment you on the slides you show about monitoring the devices that you can go to now. The technology, that's important. You're showing that.
Thank you, and I hope it actually becomes important for clinical practice. Yes, ma'am.
Call me Madam Zell. I'm frustrated by what you explained about the way they measure our blood pressure now. I'm seeing, since the blood pressure varies all the time, I don't know if I have a good reading on my blood pressure, the way the institutions take it, and they maybe take the lowest number that you have taken. Your reading says. If they take it over a half hour, you have many different readings. It's so frustrating. I don't really know that my reading is correct. And how does one know it's correct? And you never mentioned the word stress. Doesn't stress affect your blood pressure? Isn't that a big component that could cause your blood pressure to go high in the day and maybe be a warning? I mean, not put you in a position where hours you have a high blood pressure, which you shouldn't really have. And how would you know?
So the question refers to more than one blood pressure reading, and what's important, and how do you know which blood pressure is the most important, and how often do you have to take it to get the most accurate result, and also the effect of stress on, yes. So the effect of stress permeates much of what I said. So the blood pressure in clinic, the one-time routine clinic blood pressure, is not considered as accurate as other things. So what are those other things? It's not as accurate as home blood pressure readings for predicting risk. It's not as accurate as a rested clinic blood pressure where you wait 5 minutes and then average 3 readings and use the average to assess risk. A routine clinic blood pressure is not as accurate as a 24-hour ambulatory blood pressure monitor. So, and the more readings you have, the better, the more accurate it is when you compare it to gold standard. So the answer is the more data that you have, probably the better. In terms of what is used in clinic to gauge what should be done, I think an average of rested blood pressures in clinic is probably the most accurate thing that we know or I know how to assess blood pressure. And when taking blood pressures from home, this is a difficult thing because people come in with very different modalities of having measured their blood pressure. Some people have a piece of paper with 12 readings on it. You don't have time to sit there and calculate an average over those 12. One care provider I would not fault somebody for kind of looking at a list of blood pressures at home and getting a gestalt of what the average blood pressure is at home based on that. That oftentimes is what is used in a busy clinical practice. So what I'm saying is that the blood pressure does vary over the day. It certainly varies with stress. In some patients, stress affects the blood pressure a lot more than other people. But the average blood pressure, I think, wins the day. The more readings you have, the more important it is to take them all into account. And the more important it is to, if there's any discrepancy, is to focus on the ones that are done at rest.
Well, when they do that with the cuff, they measure you.
Yes.
In the same period of time when you're rested and sitting there, they get different readings. And different cuffs give different readings. I don't think the cuffs are very good. And what's our alternative?
So the cuffs that are used in clinic should be regularly, routinely calibrated against a mercury manometer or a mercury sphygmomanometer in order to give an accurate reading at that time, even though that blood pressure in 5 minutes may change. But at that moment in time, it should be giving an accurate reading. And most clinics will have routinely calibrated cuffs to be used for blood pressure measurement, number one. Number two, the blood pressure certainly does vary over 5 minutes. But if they're all rested blood pressures, taking the average of those blood pressures is probably the most reliable thing that one can do, rather than taking the lowest or the highest of those values. Third thing has to do with stress. So stress affects people's blood pressure very differently. If you compare a rested blood pressure versus a walk into clinic, sit down and quickly take the blood pressure, that blood pressure can be lower with the rested blood pressure. It can be higher with the rested blood pressure. On average, it's slightly lower, but it can be much, much lower, or sometimes it can be the same, or sometimes a little bit higher. Everybody is a little bit different, but you have to assess in larger populations which of those types of measurements are the ones that are better associated and more closely associated with events that matter. So cardiovascular, risk for cardiovascular events. And so the average wins the day, rested blood pressure wins the day. And if you have home readings, kind of taking a gestalt of those home readings is probably more accurate than simply relying on the run in, quickly sit down, be stressed, routine clinic blood pressure. From all assuming a calibrated cuff. If the cuff is not calibrated, everything I just said doesn't matter. The cuff has to be calibrated, and don't trust uncalibrated readings for any of the above.
How would you know if it's calibrated though? They don't tell you that.
So if you have a home cuff and you trust your clinic doctor, I would bring your home cuff to clinic to have it calibrated, where you can measure blood pressure in one arm with your cuff and the clinic blood pressure device on the other arm, and then flip them and do both. And if both of them are 10 millimeters of mercury or less, it's probably accurate.
You mean switch arms when you say flip?
Yes. So you measure home on the right and clinic on the left, and then flip it. So home on the left and clinic on the right. And if both of those comparisons are close enough, then that I would consider a calibrated cuff. If you don't have an inherent trust in your care provider's blood pressure cuff, then I would bring that up with your care provider, because that one should be well calibrated.
Are they accurate over a period of time?
So the question is, are they accurate over a period of time? Since I don't have a good biophysics degree and I don't work for Hewlett-Packard, I'm probably the worst person to ask about the oscillometric devices and their accuracy over time. The ones we've had in clinic, we've had for a long period of time, so I'm assuming that they stay accurate for a long period of time. Yes, sir.
So you had deferred this question for, you said that you don't want to talk about the different types of blood pressure, and you asked them during Q&A. So is this a good time to bring that question?
Yes, it is. Go ahead.
So can you sort of give the various kinds of, so I have two questions. Given the importance that you brought out for the home measurement of blood pressure devices, and the accuracy of those devices seems to vary quite a bit, do you have recommendation, or is there a source where we can go for finding out the, accurate devices?
Yes.
That's
So-
one thing, and second thing is like, doctors have these different kind of blood pressure medication. Can you which is sort of very confusing,
Yes.
Can you say anything about
I can.
the metrics of these medications?
So I'll address the two questions separately. The first one has to do with what device should one use at home, because accuracy matters. And the second question has to do with which class of antihypertensive medications should I use, because it might matter. So in terms of the different cuffs they have at home, there are several brands in which the majority of the cuffs that are sold by that company are validated. And when I say validated, there are three governing bodies that really do validation. There's one in particular that I go by simply because I know their website address and I can look and see, and they have a link to the blood pressure journal in which they published their validated readings. So that's the European Society of Hypertension. It's called the ESH/IP2 protocol. But there's a call for a number of different agencies to get together and come up with a standardized way of validating blood pressure. So some of the brands that my patients have, and some of the brands that show up on these validated lists, Omron is a standard company. Withings is another standard company. Welch Allen is another standard company. Philips is another standard company. I would say probably Omron devices are probably some of the more popular ones that are sold. If you're going with a home device, I would get an upper arm device rather than a wrist device. And the reason I say that is because there are more upper arm devices that are validated than wrist devices. But most Omron devices are validated and they publish their validation data. So I have tended to trust theirs. Some companies, including Omron and Withings, have something in their device that allows it to be Bluetooth connected to your phone. So there's an app on your phone, and that depending on your provider, can transmit that data to your provider. And at Stanford, that's possible. And so it makes it more convenient to have that data transmitted so you don't have to log it. And if you're really interested, the European Society of Hypertension ESH-IP protocol, and I forget what, I think it's International Protocol 2, is a standard that was developed in 2010, and they have a website, and they have a listing of all the devices, whether it's wrist, whether it's upper arm, a link to the paper, the range of blood pressure that it was validated over, the age group in which it was validated over, how many patients it was validated over, the company, the serial, not the serial number, but the catalog number of the device, etc. So most Omron devices are validated. Most Withing devices are validated. And so a popular brand has likely gone to the trouble of getting validated because there's a market pressure to do that. And so that's what I would use. And then if you have any questions, I would calibrate it against your physician's device. The second question has to do with different types of medications. So this is a bit of a longer answer, but there are many different types of antihypertensive medications, and they're named based on their mechanism of action. And there's an alphabetical term in ABCD, which is very helpful, so we go by it. So the A refers to two types of medications that work slightly differently but work in a related way. One are called ACE inhibitors, or angiotensin converting enzyme inhibitors. The other A are angiotensin receptor blockers. And so they inhibit the renin-angiotensin system. That is one tried and true class of medications. The second, the B, stands for beta blockers. The C stands for calcium channel blockers. And the D stands for diuretics, or putting it simply, medicines that make you pee more and get rid of salt in the urine so that you lower the salt in you, and so you lower your blood pressure. Those are the 4 classes of medications. The A, the C, and the D are considered first line. So not the beta blockers. So when I say first line medication, I mean patient with no other medical conditions and has high blood pressure, and it's high enough that you got to take a medication. It's a potpourri of choices, and there's no right answer as to which medication is necessary for one patient. That's why I started with that adage that it's better to treat the blood pressure with something than nothing. Some people will certainly respond better to a angiotensin converting enzyme inhibitor versus a calcium channel blocker. And people will have a variety of responses, just like some people will respond better to salt or to obstructive sleep apnea therapy or exercise or weight loss. But we don't do tests to gauge how much people will respond to a particular medication. So it has not come to clinical fruition that somebody has a genetic score that says they're going to lower the blood pressure the most if they take an angiotensin receptor blocker. Or they have the clinical criteria that says that that medication will work better for them for lowering their blood pressure. So this is often done in an empiric fashion. So a physician or care provider will use one of these 3 classes of medications as a first-line medication, and then depending on side effects, will gauge whether to, and response, will gauge whether to go up on that medication or move to a second class and begin using that medication. There are some patients that have high blood pressure but also have other conditions. So a good example is someone who's had a myocardial infarction or a heart attack. Beta blockers are considered a medication to give patients after they've had a heart attack to prevent a second heart attack. And so beta blockers also lower blood pressure. So it's a perfect kill 2 birds with 1 stone indication. So even though beta blockers are not considered a first-line medication for blood pressure, they're a perfectly reasonable first-line blood pressure agent for patients that have those conditions, or patients that have heart failure, or patients that have an arrhythmia. A beta blocker is a very nice first choice for that type of patient. There are other conditions, conversely, where a angiotensin converting enzyme inhibitor or angiotensin receptor blocker, which is an A, would be a good first-line choice, superior to a B, a C, or a D. Chronic kidney disease would be that example condition, or diabetes would be a very good example condition. There are certain classes of medications that are better based on your racial ethnic background. So African Americans will tend to respond much better to a diuretic versus a calcium channel blocker or an angiotensin converting enzyme inhibitor. And so it depends on the patient and other conditions, but there is a certain amount of empiricism to the picking of medications and also to the pattern which is used thereafter in terms of ramp up, move over, or keep low dose synergy across multiple medications. I would say that the latter strategy is probably more commonly employed now because our population is aging and side effects play a much larger role in how we treat patients. And so a lower dose of more medications is probably safer from avoiding side effects than a high dose of one medication before moving on to the second medication. And so that specific strategy and which medication to use is kind of an open question, which is why I didn't want to spend, I already ran half an hour over, I didn't want to spend too much time on that particular question, but there are conditions very clearly that one medication is the first choice for, but if there's no clear reason, an A, a C, or a D is kind of pick your poison.
Quick follow-up. So, like you said, empiricism seems to be the key here. I mean, and it could be that, we have no way of knowing how good is this particular physician, in some sense. So I've seen that they sometimes say, particularly the D category, it can also cause blood pressure to become very low sometimes. So they say, should you take boost up more medication? Let's not, instead of 20 mg, let's go to 40 mg versus let's stay with 20 mg, but go to this D category of medication, So how do you sort of decide those things, or do you take a chance with your physician?
No, so in part, yes, because there's no right answer. The proof is in the pudding. the proof is in the response that patients have. So lowering the blood pressure to target is more important than the choice of medication if there's nothing driving the choice of medication. If there's something driving the choice of medication, a comorbid condition like heart disease or a comorbid condition like chronic kidney disease, yes, then there are clear choices for a first line and even a second line agent. But if there's nothing driving that choice, then it's the response. And it is a reactive strategy. We don't sort of send a test saying ACE inhibitor sensitive, check, we'll give you an ACE inhibitor. So a lot of times it will depend on the comfort level of the care provider as to what they're going to choose first. And so there is some empiricism that comes into play. But there are rules that we go by, either in terms of, so a great example is if you have a condition where on clinical exam or from history one realizes that swelling is a part of what a patient has, and they have high blood pressure, we'll oftentimes reach for a D or a diuretic because we're anticipating that that's going to help lower the blood volume and lower the blood pressure more than one of the other agents. But that's not always the case, and we don't always have clues that help us. Sometimes there are blood tests that patients have that will drive the choice of medications. Sometimes you can kill two birds with one stone. Sometimes people have conditions which contraindicate certain medications. So for example, a thiazide diuretic is a very effective blood pressure agent given by nephrologists left and right. If you had a severe history of gout arthritis or a severe history of hyponatremia, most physicians or most care providers would pause before starting a thiazide diuretic. So there would be contraindications to certain medications too. So it depends on the patient and depends on the other conditions that they have. But if all of that is off the table, it's by empiricism. Yes.
You mentioned coffee somewhere along the way.
Yes.
Could you say more about coffee and how that relates to a home monitoring regimen?
Yes. So the question has to do with coffee. So in this case, I'm referring to caffeine. Decaffeinated coffee doesn't matter. But caffeine can raise your blood pressure. And so there was one clinical trial, as an example. There was one clinical trial that I was a part of where we had to had to make sure that patients had a certain blood pressure or below in order to safely enter the clinical trial, because the medication they were getting, while beneficial for one condition, tended to raise the blood pressure. So we had to make sure that they were under a certain target in order to qualify for the medication. And patients would come in, and if their blood pressure was above a certain level, and you asked them, did you just have a cup of coffee? It's morning time. You probably got up very early and drove all the way to Stanford and needed something as a pick-me-up in the car. Like, did you have coffee before you got here? And they say yes. We would tend to wait a little while and then retake the blood pressure, and it would be perfectly fine. So I use that example, that anecdote, as a way of saying that caffeine can raise blood pressure acutely, so it affects one's interpretation of the reading that you have. But if you were to take 24-hour aggregate readings over a population and say whether caffeine was a risk for hypertension or not, I would say it's not a big risk for hypertension. But if you were to look at the individual reading and what decision is being made on an individual reading, caffeine does matter. So that's why it's an important part of the history, because certainly if your blood pressure is less than target and you just had a cup of coffee and you show up with a blood pressure that's too high and you never drink coffee, you just happen to drink it because you came to Stanford and Starbucks was the only thing open on the way, you probably don't want to get a whole new medication that you're going to take every day for the rest of your life. So it does matter, but I'd say it matters more in the short term. Some of the risks that I talked about there were things that matter in the long term.
So how would a routine coffee drinker modify their monitoring routine in order to not skew their readings?
Take the blood pressure before they have their cup of coffee.
But that's one time in the day. Maybe that's in the morning when you just get up before you have the coffee.
Right.
Then you have the coffee. If you want to monitor again during the day to get 3 readings in a day or 2, how long do you want to wait?
I would say an hour and a half to 2 hours after the cup of coffee is perfectly fine.
Okay.
Yeah. If you're drinking coffee frequently throughout the day, I often use that as a surrogate to start asking about sleep apnea, though. because if somebody has fatigue from not getting a good night's sleep because they have obstructive sleep apnea, and they feel that they need caffeine throughout the day to stay awake, there's a reason behind all of that caffeine. And so we have diagnosed obstructive sleep apnea based on a history of excessive caffeine intake. So that's something that I ask about. If it's purely just habitual, and it's not something that one's likely to change, and there's any reason to change, then I would just measure it sort of not immediately after the cup of coffee in order to.
Is there any amount that's considered excessive? Because this can be a lot of variation.
Yeah. The question is there any amount that's considered excessive? I don't know the answer to that question. Certainly, a lot of coffee has other side effects for other things, and so I imagine that there is an amount that is considered excessive, but I probably can't tell you exactly what that is. Yes, ma'am.
So the baby aspirin, does that affect the blood pressure?
So the question is, does baby aspirin affect the blood pressure? Not appreciably, no.
No. So, okay, taking it every day is not a problem.
Correct, it is not a problem. Yes, sir.
What's the correlation between heart disease and high blood pressure? Does one cause the other or vice versa?
So,
how much of a factor are one to the other?
yes, so the question is, what is the correlation between heart disease and high blood pressure? What's the chicken and what's the egg? So we as nephrologists, and again, I can make fun of cardiologists because my wife is one of them. High blood pressure is a cause of heart disease. Heart disease is not often a cause of high blood pressure. In fact, severe heart failure usually presents with a lower blood pressure.
You say it leads to a lower?
Yes, severe heart failure does. High blood pressure can lead to heart disease, usually not the other way around. The exception to that would be the rare case of coarctation of the aorta, which is not technically heart disease, but is close enough anatomically, where one would present with hypertension in the upper extremities and lower blood pressure in the lower extremities. That's not really a heart disease per se, but it's the closest thing to it, where the heart would be the cause of the high blood pressure. Otherwise, generally, no. The heart is not the cause of high blood pressure. It's the effect. Yes, sir?
Going back to the physical part of the blood flow, smoking does cause that stuff in the arteries that causes the high blood pressure, right?
Yeah, so the question is about smoking. So smoking is a risk factor for atherosclerosis, which can affect your risk for hypertension.
Because it physically constricts the artery, right?
That's correct, yeah. So blood pressure is the Ohm's law of medicine, right? It's the pressure is the flow times the resistance. So things that increase your systemic vascular resistance are going to increase your systemic blood pressure for the same level of cardiac output. Yes, ma'am.
Low blood pressure, you related it to a heart disease. What do you consider low blood pressure?
So the question is about low blood pressure and heart disease. So the specific type of heart disease that can be associated with a lower blood pressure is systolic heart failure. Usually, so interestingly, the hypertension guidelines don't actually say what is considered too low a blood pressure. Usually what is considered too low is when one has evidence of a lack of blood flow to vital organs when the blood pressure is below that level. So that would be considered low blood pressure. So an example of that would be if you're dizzy at a blood pressure of 105 systolic blood pressure of 105 millimeters of mercury. If that makes somebody dizzy, then that's probably too low for that individual. If somebody's perfectly asymptomatic at a blood pressure of 105 millimeters of mercury, I would not say that that's too low. There are also patients by extension that have a systolic blood pressure of 91 millimeters of mercury who have no symptoms whatsoever, and that's perfectly okay for them. There are patients that have a low blood pressure and have evidence of a lack of blood flow to vital organs. So dizziness would be an example of a low cerebral or brain blood flow perfusion. There are patients that have elements of kidney disease when their blood pressure is too low. And we measure that on standard blood tests and would probably advise the blood pressure to not be so low if that were the case. And then there are other organs that can be measured in other ways to measure that. And there are generally causes of low blood pressure, specifically if it's more symptomatic. But we usually don't chase low blood pressure unless it's symptomatic or just the number is way too low. And I would say any number less than a systolic blood pressure less than 90 would be something that is out of the norm. But I don't want you to leave here thinking that if your systolic blood pressure is 95 millimeters of mercury, that there's something wrong. It depends on the individual, and certainly the more asymptomatic, the less likelihood that that blood pressure is too low. But the more symptomatic, the more likely it is that that blood pressure is too low. Yes, sir.
So in the device I have, they have third reading also pulse rate, and you didn't mention that at all. Is that?
I'm not a cardiologist. I don't talk about pulse rate. Yeah. So the question was about pulse rate, and most of these devices will measure the pulse rate also, and the pulse has it's a whole several sets of lectures that we didn't have time to get into. But in general, as a nephrologist, I don't pay that much attention to the pulse rate, but it matters for certain things, just nothing I had the time to talk about today. Okay, thank you guys very much. Appreciate it.